Okay, we have two presenters joining us here this morning. Celia Barker is Project Director, Strategy and Impact at Meals on Wheels America. And Lucy Teilheimer is Chief Strategy and Impact Officer at Meals on Wheels America. And with that, I'd like to turn the floor over to Lucy and Celia. Welcome.
Thanks, Steve, and thank you to everybody who's joining us today. We're happy to be here with you. Let me just take a minute to review the agenda for the next 45 minutes or so. First, I'll just give you a sense of what we're trying to accomplish, go over the objectives of the project that we're going to be talking about today, give you a sense of how that project was executed and some of the key learnings, and then give you some suggestions for moving forward. So that's what we're about today. So I'm going to jump in and give you a sense of the project objectives. First and foremost, Meals on Wheels America is really about supporting and enabling the network of thousands of local community-based Meals on Wheels programs to be able to extend their reach and impact to the greatest extent possible to serve seniors in need who are faced with hunger and isolation. And so the primary purpose of this project was really to try to open up revenue streams, funding streams that would enable programs to do that. We all know what some of the limitations are that these local programs face, and so what we're really trying to do is innovatively and creatively look for new ways to drive revenue to local programs so that they can meet the needs in their communities. So that's really the first objective. Part of that was we really wanted to explore how we could leverage the concept of pay for success with Medicare Advantage plans as a way to really try to scale the opportunity for driving revenue to local programs. So that's the first objective. Secondly, we seek always to demonstrate the value of what we refer to as the more than a meal model, but in this case specifically to help Medicare Advantage understand what is the unique advantage of community-based Meals on Wheels services, both in terms of improving their outcomes and from a financial cost-saving perspective. And so this was an opportunity for us to continue to drive that message of more than a meal to Medicare Advantage plans that are increasingly looking at how can they better serve this high-need, high-risk population that we see on a regular basis. And secondly, it's really to position Meals on Wheels programs to be competitive in the marketplace for those Medicare Advantage contracts, particularly as there's more and more focus and opportunity around supplemental benefits. Thirdly is to continue to grow the evidence base for this more than a meal model. We've been engaged in research for many years, really aimed at demonstrating the true value and impact of Meals on Wheels services, both in terms of the seniors and their ability to stay safe and independent in their home, as well as saving healthcare money. And every time we enter into a new partnership or an arrangement, we seek to gather the data that continues to build that evidence base, and this was part of that strategy as well. So those are the objectives for today, and I'm now going to turn over to my colleague Celia to start going through the project timeline and specifics.
Thank you, Lucy. So we started this project in March of 2017, and we started the delivery of the services in January of 2019. That's obviously an intense and long project. So we secured a grant through the Nonprofit Finance Fund in March of 2017, and we started exploring what MA plans we could work with. We were able to secure an MA plan partner by June, so about 3 months to find the right MA plan. We moved to a decision on what we were going to go after in November of 2017. We selected the 2019 MA bid. Between the time that we selected that and when that bid was due in April of 2018, we figured out all the details around the geography, the intervention, and the economic modeling. We had that bid submitted in June of 2018 from the health plan to CMS, and that bid was officially approved in October of 2018, which allowed us to start those services in 2019. So we did start those about 6 months ago now. how Pay for Success could tap into some investment to build up the CBOs to provide these services to a Medicare Advantage plan. If you've ever seen a Pay for Success triangle before, you'll notice that here we have a slightly different model. So MA plans already have home delivered meals vendors. This is something that's been part of Medicare Advantage for a while, but it doesn't offer our more than a meal model. So we know that that's a little bit more expensive, but it's because there's a value add in those wraparound services. And we decided that Pay for Success would be a great way to demonstrate that our solution actually added no additional cost to the MA plan due to the savings that they'd see. So we used our Pay for Success idea as a way to get in with the MA plan. They recognized it as being an innovative model that aligned with their interests and enhanced their meal delivery benefit, but it also increased their ability to provide good services to their Medicare Advantage members, and they wouldn't have to pay for it unless we accomplish our outcomes, which is always appealing. So as you see here, number one, the plan was for the investors to provide the capital to Meals on Wheels America. Then Meals on Wheels America would manage that flow to the local community-based providers, and we would do that based on how much they needed to serve the MA plan population. And then the local service providers would use that upfront funding to pay for the capacity that they needed, as well as the services to the MA population. And then once we achieved the outcomes, our targeted outcome was hospital utilization reduction, then the MA plan would pay back Meals on Wheels America, and Meals on Wheels America would pay back the investors. So that's the flow that you see here. The big difference between this and a traditional Pay for Success model, as traditional as those come, is that the MA plan and the investor would not actually have any contractual relationship as they tend to have. Instead, Meals on Wheels America would play an intermediary position and manage all the payments, which reduced the perceived risk from the health plan's perspective. In that way, they were more of in a performance-based contract instead of in a more complex Pay for Success contract, which initially was a little bit daunting to them. So we will move into our key learnings. Through the almost 2 years that we were working on this, we definitely learned a lot. First and foremost, we learned that the bid cycle for Medicare Advantage was key to participating. So knowing that you want to participate with an MA plan, we would suggest starting conversations about 18 months in advance of when you want to deliver services. This gives you enough time to really talk with that MA plan about what it is you want them to pay for, what it is you want to provide their population, and then they can get that into their bid and you can deliver those services through their processes. So the example here is starting a conversation this year in August would be ready for the June 2020 bid, which would be the services of the 2021 calendar year. In the same line of the Medicare Advantage learnings is simplify. Just simplify everything all the time. So those first few interactions, we keep things as cut and dry and simple as possible. Pay for Success is a wonderful tool, but it can get very complex very quickly. So keeping those things as simple as possible and being open. We went in with a Pay for Success idea, and we moved to performance contracting idea without ever changing what we wanted to accomplish, both from what we wanted to get out of it and from what the health plan wanted to get out of it. And the third one, with a focus on Medicare Advantage, would be that barriers exist, but they can definitely be overcome. So one of the barriers would be securing financing on the bid timeline. Obviously, as you just saw, bids are submitted in June, they're accepted in October, and you have to start services on January 1st. So this is a pretty tight timeline for securing those investors, but it's definitely possible if you've done the pre-work and you're ready to go and seek those investors and maybe have some caveats around their investment being that those bids are accepted. The second one is members paying, but the plan not paying is an interesting position that the MA plans can be in. They're not comfortable with increasing their member premiums without being certain that they're paying. So having proof that those outcomes are really going to occur is going to be critical there.
Okay. Going on to key learning 2. And this is in line with the keeping it simple, is to make it easy for the plans to say yes. And first is to really understand the audience with whom you're speaking. Understand who they're trying to serve amongst their members. Our experience is that Meals on Wheels is a good match for for particularly the high need, high risk population. So just understanding who it is that they're trying to serve, what their strategic priorities are. Celia already made reference to the fact that they have internal processes around how they prepare their bids that have to be submitted to CMS, and some of them start very, very early. Particularly the larger plans have very elaborate processes working with their individual local markets. Smaller plans may be a little easier to work with in terms of timing. The bigger plans will require, there'll be more process and more timing associated with that. So understanding their contracting process. If you're able to engage a subject matter expert who really understands Medicare Advantage, that would be particularly helpful. We did do that in the case of working with the Medicare Advantage plan, and it was hugely helpful to us because they had a deep understanding of how they do their own economic modeling, how they do return on investment modeling. She understood the local markets and what was important to them, so that can be very, very helpful. Continuing on, another important area is to make sure that you have a strong business case, that you have done the due diligence to demonstrate to them why this is a good business decision for them, and to really be able to show them the data that will demonstrate what their return on their investment will be. It will be important to speak their language, and they do have their own language, so becoming very facile to understand how they speak to each other, what terms are important, that is a piece of the preparation. And the other is to really think differently about how you price services. Medicare Advantage plans, particularly in our arena, have been used to paying a certain price per meal. In our More Than a Meal model, what we were really thinking about was a service, not just a meal. And so we were trying to open their minds to think about the service and the associated pricing differently than what they're used to. And I think that's important. There's an ongoing educational process there when you're working with them. Moving right along, it is the next area that's really important. Is we all know by now that data is king, and it's really important to have the systems and processes in place at the national level and at the local level that will allow seamless, compliant collection and sharing of data relative to the service that you're providing and the clients who are receiving those services. So that is absolutely key. Also want to make sure when you're talking to a plan that in light of really wanting to be sure that we benefit from the data that's collected, that when you enter into an agreement with a health plan, clearly they cannot provide specific client-related information, but getting data in the aggregate that will help you understand the impact of the service that you're providing is something that you really need to be sure gets written into any contractual arrangement with a Medicare Advantage plan. And lastly, no Medicare Advantage plan is going to want to go into something like this without the potential of growing it. We need to be able to be sure that in any one market that there's capacity to serve any member in that market wherever they live, and their markets can be interestingly spread from a geographic spread. They can even cross states, right? They cross multiple counties, have to make sure that whatever requirement is necessary at the local level can be met in terms of serving all the eligible members. And beyond that, that if it's successful, and most of these plans do want to start small, they'll start with a pilot with the eye towards being able to scale to other markets. So thinking about scale potential and the capacity to be able to grow the relationship over time will be important to a Medicare Advantage plan.
Yes, and on to our third key learning. So we know that there's a regulatory environment that Medicare Advantage lives in that's very stringent and something that not everyone really interfaces with in delivering community-based services. So the regulatory realities could come in direct conflict with what you want to accomplish. We found this specifically around what we wanted to provide was one of the more regulated environments of meals. So in Medicare Advantage, they have a uniformity of benefit clause, which means anything that is a benefit, it's a very strictly defined service that's provided to Medicare Advantage members, has to be provided across the plan to all members. So there are new ways that are becoming a little bit more lax in this by offering supplemental benefits to folks with chronic conditions and other situations. But for the most part, a benefit that's offered to one member must be offered to all members. This definitely affected us. It also means that it doesn't allow you to have a good feel for what the volume will be, and that affects your ability to project a budget. So knowing that everyone who qualifies or everyone in the plan in its entirety will be eligible for the benefit only tells you who's eligible, not who will be receiving it. So it's definitely a tricky area that is getting a little better with the new supplemental benefit guidance, but is still a big note to keep in mind. The second area is the annual bid cycle. So the annual bid cycle happens, as we've talked about, bids going in June, getting approved in October, starting the following year. If your project were to span multiple years, this wouldn't be feasible for an MA plan. Because they have to rebid every year, they can't sign on for something that's going to cross multiple plan years. So if they didn't rebid, or the bid wasn't awarded in the following year, or some big regulatory change was made between the plan years that you were considering, this would be a huge risk to the project, and the MA plan is unlikely to sign on for that long. The other element that this affects is the implementation delay. So we know that you have to start in January and the bids are due in June. So you really have to be ready for what you're going to do by March or April in the year prior, at least with all of the definitions, really having an understanding from all parties what it is you're going to accomplish has to be done 8 to 9 months before you're going to do it. The one upside of that is you have a lot of time to do the ramping up. So it's two sides of the coin there.
So if you're considering a Pay for Success project and starting to think about, well, who should I target? Who should I try to work with? There are some things to consider if you're thinking, and they break down pretty much by the larger plans and the smaller plans. So I'm going to walk you through some of the pros and cons of each of those, just to give you some fodder for thinking through what you might consider. So starting with the bigger plans, and on the pros side, regional and national players have capacity to scale successful interventions across large populations. And for service providers that have with regional or national growth ambitions, this can be very, very important. But for every upside, there's a downside. For the largest payers, it may be hard to convince them to dedicate the time and resources of structuring a project that serves, at least at first, only small groups of enrollees. Large payers often have significant financial resources to commit to initiatives. For some payers, they may not view that prospect of supporting a capital investment as really highly valuable, but there are obviously other benefits to a Pay for Success project. Larger payers with large number of employees will have personnel identified to plan and design and implement the project, so that's all good. Those people will probably need to interface with staff from other departments, and with anything, a new investment, a new kind of project is likely to be resource intensive and identify and involve many staff across the organization, and that of course can contribute to delays and communications issues. And while the larger plans are likely to have data sophistication, it does take time to really make sure that you're having access to the right people to do the kinds of analytics in a timely way that will support all of the financial modeling that has to happen in a pay-for-success project. On the con side, the large payers' significant resources that there are often parts of the company that operate in silos, and they're often in different physical locations, and it can be very difficult to get all the right players around the table frequently enough to support the project and to make sure that everybody who needs to make decisions and weigh in on different aspects of the project is appropriately engaged. In any large Medicare Advantage plans, there are some consultants who will tell you it's all about the actuaries, and it's really important to engage the business side of a Medicare Advantage plan if in fact there's likely to be any kind of successful agreement around a pay-for-success project, and this can take a lot of time. Large payers with significant business lines in government, obviously Medicare or Medicaid, they tend to be more risk averse, particularly in our world where they've often been providing a meal benefit, albeit a post-discharge, probably a once-a-week delivery, of frozen meals for years, and they're not yet convinced that taking on a more comprehensive service is likely to address the other needs that an individual may have, whether or not they're really ready to go there. They're not sure yet what CMS will and won't support when the time comes, and so they tend to be a bit risk averse, and that makes it a little harder to convince them as to why should I do this, and is it really going to benefit our members and us. In terms of the smaller plans, on the upside, those plans are likely to have fewer resources, so the idea of tapping into a third-party investor to remove some of the risk is likely to be even more appealing to them than it might not be to a larger plan. All executives in a small plan are likely to know who has to be engaged. It's probably easier to get all the people who need to be involved in the decision around the table together and move things forward. They also are probably likely to be intrigued by the idea of positioning themselves to be more competitive with the larger plans, and because this is something that's new and innovative, it could be something that's intriguing to smaller plans. On the con side, however, the smaller plans tend to be derailed by shifting strategic priorities. We talked to a number of plans before we started working with one plan, and there were a number of instances where we had very productive conversations and started down the road, and then something changed, and they just did not have the bandwidth to support multiple initiatives, and they made shifts and decided to focus on something else other than the Pay-for-Success project. They may be operating in a much smaller geographic area, which is going to limit the potential of scale, which ultimately will limit the potential impact from a financial perspective and the return on investment. And because they'll have less resources, they may have less sophistication on the data front, less time, staff power to invest in the project. So those are just some things to consider as you're thinking about who might I approach for a possible. Our big learning here would be think about the mid-sized plans here, because I think that there are potentially some opportunities where they're large enough to mitigate against some of the cons for the smaller, but not so big that they becomes unwieldy to deal with them. So this slide here just gives you a sense on how the market breaks down a little bit, and you can see that there are literally a handful of plans that make up more than half of the represent more than half of the enrollees in Medicare Advantage. United Healthcare being one of the largest, Humana, and then it says all, that's an all other, is about 22%. And then you see there's a number of smaller plans. So there's lots of opportunity to be trying and testing something new and different in this arena. So some thoughts for going forward. Based on our experience, we think there are basically 3 areas that could help move the field of pay for success forward. So let me just give you a quick overview of those, and then we'll just open up for questions. So first is that it's important to know that these transactions do require a significant amount of effort, and to the extent that we can engage philanthropy in this pay for success world to help support this work, that will be important. We actually were fortunate to get 2 grants from the Nonprofit Finance Fund. That went a long way to supporting our staff time, to helping us engage with external experts in pay for success transaction deals, in contracting with an evaluator, an external independent evaluator, to help us define and measure outcomes. And that is one of the important aspects of a pay for success project, is that once you've agreed on outcomes, the expectation is that you will contract with an independent evaluating organization. Usually could be like, we use the Urban Institute, we were talking, could be an academic and university, but that there is that kind of skill set and independence involved in the evaluation, since repayment is based on achievement of those outcomes. So looking to philanthropy to help provide support for that project development work is something that we would like to see more of. The other piece is that philanthropy can also help in terms of making the investments that we know need to be made to help ready community-based organizations with what they will need to be able to partner effectively with healthcare. And that could be everything from meeting compliance requirements to building their data and technology infrastructure to building their staff capacity, whatever it is that they need to be able to deliver. Next, particularly in this world of Medicare Advantage, is to continue to leverage our advocacy arms to work with the Centers for Medicare and Medicaid Services, and to really help to try to encourage them to support the design and testing of these innovative solutions. I think we've seen some progress in the last year, particularly around the expanded supplemental benefit provision, some openness to looking at new and different ways to serve this high-need, high-risk population. But to the extent that we can engage them and get support from them for these kinds of initiatives, I think that would help advance the field of pay for success. And then lastly, we still obviously all face, in the longer term, the goal of pay for success isn't to do pay for success. The goal is to drive resources to support the kinds of services that we all know stand between a person's ability to stay healthy and safe in their own homes and facing repeated hospitalizations or ultimately nursing home placement. And that this does not ultimately solve in one big sweeping way the fundamental problem of the lack of resources available to support these kinds of community-based services. So this is one way, one piece of the picture to try to address the need for those kinds of resources. But in the longer term, we all still need to continue our efforts to advocate at the federal and state level to provide the resources and pay for these services that we know are going to make such a fundamental difference in the lives of seniors, as well as save the system millions of dollars. So I am going to stop there, and we are going to open up for questions. Steve, I'm throwing back to you.
Okay, looks like we'll get to the questions a little bit early here, everyone. Okay, time to send in your questions. If you have any at this time, folks, write in, excuse me, at the bottom there. You can see a box for entering in your questions. So send them in now. and presenters will get to the questions right here. The first question, start with here, can you tell us who are the investors? Are these private equity firms or public funders?
The investors could be any of those. It can be a financial institution. It could be it could be a foundation. It's not like it could be. I'm trying to think of a different. We used a community-based. I'm trying to think of the name. There's really no one investor. It could be Bank of America, for example, has invested in some of these. It could be Goldman Sachs has been an investor in some of these. There's a wide way. It can be a state, government can even be an investor in one of these. So there's variation in who can be the investor. Mostly what you're looking for is someone who has the wherewithal to provide the resources needed to ramp up the project, who understands the value of what you're trying to do and has an interest in having social impact, but at the same time realizing some return, some financial return.
Okay. Next question, can you provide us with any contact information so that we can start to have conversations with Medicare Advantage?
Well, Medicare Advantage is not one global, right? So if you're talking about having conversations with individual Medicare Advantage plans, I can give you some suggestions, but it will vary plan by plan. And who's ever asking that question, it's a really key question, because finding the right door to go through in a Medicare Advantage plan and the right person to talk to is really important. The more traditional route would probably be to reach out to the heads of the Medicare or Medicare line of business, right? In any Medicare Advantage plan, there will be someone who is responsible for the Medicare product line. Increasingly, I would say that a place that's more likely to be open within a Medicare Advantage plan would be population health, which more and more Medicare Advantage plans are establishing a unit around population health. And so their frame of reference is a bit different than the traditional business side of the house. And so I would definitely suggest reaching out to population health if that exists in the Medicare Advantage plan. Chief medical officers is another possibility, I would say, inside of a Medicare Advantage plan. But the champions could come from any part of the organization, but I think those are probably the top three that I would suggest people try.
Presenters, are you still there?
Yes, we're here. We were waiting for you to tell us which question you wanted us to address.
Sorry, I must have some sort of audio disconnect for a second. Okay. Just to repeat here, I'm sorry I cut out there for a second. Are you able to provide any examples of services that specifically support family caregivers that Medicare Advantage plans are supporting?
You know, I'm not. I'm sorry. I don't really have knowledge of what any one individual plan may be doing for caregivers. I can certainly try to see if I can find some information for you, but I don't have that information handy.
All right, fair enough. Next question, would a Medicare Advantage plan be interested in funding enhanced services for seniors in affordable housing?
I think that Medicare Advantage plans are looking with an open mind at what expanded supplemental benefits. I think if seniors are in affordable housing, I don't see why that's a barrier to services. If they're a member of the plan and they meet the criteria that the plan is looking at, I don't see the fact that they live in affordable housing as being any reason why a Medicare Advantage plan wouldn't offer a benefit to those individuals.
Okay. Next question, does Meals on Wheels operate in an affiliate or chapter model? It would be great to better understand how to implement this across a CBO model where affiliates and chapters operate as individual 501c3 organizations.
Right. Meals on Wheels, local Meals on Wheels programs are all independently operated. So we do have that kind of model. The way we try to address that, because Medicare Advantage plans don't really want to engage with multiple local organizations, that becomes very burdensome for them, is we work with them, and then we subcontract with the local programs. We put together the processes and systems to manage referrals and billing and reporting in a centralized way for the program. So the programs we're operating as a network instead of a one-by-one. That doesn't preclude individual local programs for procuring their own contracts, but most Medicare Advantage plans will cover a geography that's bigger than any one program. So to the extent that they can work together as a group, that will work better for a Medicare Advantage plan.
Okay. Next question. Is there a risk in not getting reimbursed for services provided? Have you found that clients needed approval which postponed them beginning services?
So this is a great question. It's going to depend on your contracting situation, but for instance, in our current contract, we have an opt-out. So once the care manager refers the Medicare Advantage member for the services, their physician would have to opt them out of the services in order for them to not receive them. So eligibility checks are done. That's always going to be a process with Medicare Advantage, but we've automized that, and we send out these opt-out notices. The physician has 1 day to opt out. We have yet to have a single opt-out occur. And otherwise, we are able to provide those services as they were referred. So that's really worked well for us. It's an implied approval, but for our services that works. Now, that would not necessarily work for every service. It depends on the structure of the Medicare Advantage plan as well as the structure of that benefit. So because of what we're providing, we were able to do that, but I would suggest, if at all possible, the opt-out system is working very well for us, so we come with the implied approval, and you have to revoke that in order for us to not provide services. And we do keep it on a very short 1 business day timeline, which allows us to know right away if we should not be delivering those services.
Okay. Next question. Who in the Medicare Advantage plan did you first reach out to? Is there a specific position that tends to be the best first approach?
Well, similar to what I was saying earlier, in the case of the current partnership that we have with one of the Medicare Advantage plans, we had some relationships with some folks, and we got connected to the population health group in that plan. That is who we ended up working with. The population health group in this particular plan reports to the chief medical officer. They are also the keeper of the strategic priorities, if you will, of the company. And so we happened our way in through connections into the place where strategically what they were trying to do for their members was very well aligned with what Meals on Wheels services is all about.
And I would just add to that, our biggest success has been when we've had a friendly connection. So being able to use people from other organizations that have those connections or our other associates who have those connections has allowed us to get pushed to the right person. So even if their internal contact to that MA plan is not the right person to talk to, sometimes that friendly passing off to, say, the population health group allows them to have just a different opinion. You're not just someone coming in off the street. They've been referenced by someone else, and that really led to some of our success.
All right. Next question, how did you find a content area expert in Medicare Advantage?
I think this is a great build on what we were just saying. So first off, by definition, Medicare Advantage is dealing with a 65-plus population. So there's generally some awareness and sensitivity to challenges and issues that seniors are facing. The bigger plans have done a lot of research and a lot of analytics on how that population is growing and changing, and what the chronic conditions are amongst that population. They've done analysis on claims, and so they have a pretty good understanding of what's happening in that population. So when we got connected to that population health group, not only were they well aware of the needs and challenges of their members, they had already strategically identified food insecurity, social isolation as key issues that they wanted to address for their members. So it was that's why I say there was a lot of alignment between what that group was looking at and what Meals on Wheels is concerned about.
Okay. Next question for you here, presenters. What are some of the wraparound services you are providing?
Right. Well, the More Than a Meal model provides a whole range of wraparound services. There's sort of a threshold level, and then there could be any number of add-ons. So the core Meals on Wheels service includes obviously the nutrition services and usually education and counseling along with it. It includes doing an in-home safety assessment and remediating for any risks and hazards that they might find in the home. For 59% of Meals on Wheels clients report that the Meals on Wheels delivery person is the only person that they come into contact with, so they're providing that human connection, that socialization, and they're providing them with connection to other community services based on their ability to be able to identify any other needs that the individual may have that, if met, could help them stay safely and happily in their homes and live independently for as long as possible. Many programs do far more than that, and they have grocery assistance programs and friendly visitor programs and pet programs and home modification programs and, very well-developed case management programs. So it can be quite extensive, the wraparound services that are available.
Okay. Next question. Do you know of other CBOs that have partnered with Medicare Advantage plans to address SDOH?
Yes, we do. And in fact, we just completed the first comprehensive network study. And one of the questions that we asked was exactly who has what kind of partnerships and contractual arrangements in healthcare, and if so, who are they partnering with? We've just gotten all that data in, and we're just beginning to mine it and analyze it. So I can't give you specific names of CBOs right now, but this is something that we do have the information, and we will be looking through that.
Okay. Can you talk a little bit more about the research data that went into building a strong business plan that showed clear benefit to Medicare Advantage?
Sure. We've been collecting data for many years. We had a contract with a Medicare Advantage plan, even more than 10 years ago, where we served 136,000 people in 36 states with a post-discharge benefit. And we had data from that helped us demonstrate the value in terms of reduced readmissions and translating that into cost savings. We had a groundbreaking study in 2014-2015 that was a more than a meal study where we did a randomized control trial where we compared people who received Meals on Wheels service with people who received a once-weekly delivery of frozen meals with people who were on the waiting list, and we looked at them over 15 weeks. And we had statistically significant results that demonstrated the value and impact that Meals on Wheels had on the quality of life, the self-assessed reporting from those clients as to their feeling of connectedness, feeling safe in the home, feeling that their needs were being met, that they were connected to other services. We have since been continuing to build our research base where we're collecting all of the local research that's been done by various programs. So, for example, there's Meals on Wheels programs in Texas that have partnered with the university there, and we've collected their research. Same in University of Florida. So we've been amassing data from a variety of sources that demonstrates the impact of Meals on Wheels services, both in terms of outcomes and ultimately use of high-cost healthcare and long-term care services. Happy to share that and information with people. If somebody's interested, they can certainly reach out to us, and we'd be happy to share some of that information.
Okay. On that front, if you would like to share your email address, I don't know if it is on the screen or if have that contact information.
Sure. For me, it's really easy. Do you want it now, or do you want us to?
Sure.
Okay. So for me, it's just Lucy at mealsonwheelsamerica.org. For Celia, it's celia.barker at mealsonwheelsamerica.org. Just the difference of a dot and a last name.
All right. Thank you. Next question. What data capacity should a CBO be able to demonstrate up front when approaching a Medicare Advantage plan? We want to be prepared and demonstrate capacity, but also anticipate that Medicare Advantage plans may dictate what data systems and capacity we need.
Yes. So another fantastic question. We learned how important data was, but understood that flexibility was the key component. So having the capacity to keep data safe and secure is critical. That for Medicare Advantage plan primarily falls under HIPAA, high-tech, and fraud, waste, and abuse. So if you've looked into these things and you can demonstrate that you are meeting those federal regulated requirements, then you're looking pretty good and pretty low risk from the Medicare Advantage plan's perspective. If you can already demonstrate how you keep those data elements secure. Unfortunately, from a health plan, anything they give you becomes part of that protected information because they're sharing it for no other reason. So demonstrating those three, HIPAA, high-tech, and fraud, waste, and abuse is the first key. The second question is even more interesting, being prepared but also understanding that they may need something. We towed this line. So we selected a software provider who was HIPAA, high-tech, and all of the compliance we needed. But we did understand that we had to have a way to work with the health plan to make that technology work for them. So we went through a process of creating a space for them specifically that utilized this software that met all of those basic security requirements. So the capacity around data is primarily to keep it secure, which is very sophisticated. It's not just a matter of having security, it's a matter of having appropriate places where you know where your data is, that you are sure it's secure. So I don't want to minimize that at all. But then just like this question implies, having the flexibility to be able to work with the health plan on how the two of you share data and how the two of you feel confident in each other in that data security. So there are things like secure file transfer sites. That's always an option. It's a pretty simple method as long as on both sides the data can remain secure. There's also ways where you can just have a software program that both of you can use. That's a different level of keeping things secure, but either way you're still dealing with making sure that users are appropriately granted access and that no one can get their hands on that data, because that, for everyone, should be the focus, is that those clients or members of the health plan are always the most important focus and that their information is always secure.
All right. Thank you. Next question. Can you describe a bit more about your experience of using an external evaluator, the Urban Institute, and how you were able to use the eval metrics to demonstrate success to the Medicare Advantage plan?
So actually the Urban Institute we used was in a different project, but I think the same rules would apply. When we used the Urban Institute, they basically were part of the project team, working with us, with the Meals on Wheels program, with our healthcare partner, to agree on what were the outcomes that we were looking to measure, what outcomes we're going to, I'll say, count, if you will, for repayment purposes to an investor, and what other outcomes was the project team interested in being able to track. And so we worked with them to identify and get agreement around all the outcomes, and then to design the actual evaluation that they would be conducting once the Pay for Success project goes in motion. So that's really the role that they play. They become part of the project, they help define the outcomes, and they design the evaluation and ultimately implement the evaluation, so that when the investor and the healthcare partner see the results, they've agreed that what that evaluation shows is what they're going to use to support repayment.
Okay. The next question. What does the Medicare Advantage environment look like for supporting individuals receiving on-demand transportation to essential community services?
It's interesting. I would have to say my experience there would be anecdotal. I have been in conversations. I was on a panel last week with a Medicare Advantage plan that talked about how they're providing transportation to people who need it. But I would say it's been anecdotal in conversations. I do think that meals and transportation are the two areas that are most commonly being looked at by Medicare Advantage plans, particularly now with the supplemental benefits. But I don't have specific data on this. These plans are actually providing transportation services, but I do think we'll see more and more of that. And certainly there are the transportation services are proactively out there working, trying to get inroads with Medicare Advantage plans for just that purpose.
Okay. Can you tell us, do you know if there are smaller, more localized, such as a single metro area, Medicare Advantage providers?
Yeah, so there are not necessarily a single metro area provider, but there are many small providers. There are also many smaller plans. So Medicare Advantage is broken down into a plan, but then it's broken down even smaller into the benefit package, and those can be as small as one county. The one thing that will be consistent between all plans, all Medicare Advantage providers across the country is that everything is by county. Every bid that they submit is by the county. So you'll see that in a larger metro area where you span multiple counties, that could span all of the counties that that metro area reaches. Alternately, you may have very small metro areas which don't fill a county, and the bid would be at least for that full county. This information is all publicly available. CMS provides monthly enrollment by plan, by county, by state. They have it broken down a lot of ways, so you can see where you can find those little pockets of the smaller areas, and definitely you see more of the smaller plans in the larger cities where they can break it down because the population is substantial enough.
It is an important, I just want to add one thing to that. It's important because the service area of a local community-based organization may or may not be similar or comparable to the plan cover area, the geography that a plan has. So oftentimes it will take multiple programs, multiple community-based organizations working together to serve a particular market, and that we encourage that. I think that working together is a good way to serve a market. But there's nothing to stop smaller programs from considering Medicare Advantage as a partner just because they're smaller.
All right. How can local CBOs get involved with Meals on Wheels America to be part of this work?
Send me an email. Send Celia an email. We try to really keep tabs on local organizations that are particularly interested. It helps us because all of these local programs are independent. Anytime we get on the phone with a potential Medicare Advantage partner and they tell us what geographies that they are interested in serving, we then get on the phone and start reaching out to programs in those areas to see if they're interested, willing, and able to participate. To the extent that we know where there are interested organizations, that facilitates that whole matching process between a Medicare Advantage plan and local programs. So by all means, let us know if you are interested in engaging in this kind of work. And we'll just keep that in our records, and then as we have these conversations, we'll come back to you when there's interest in that market area.
Right. Next question. Meals on Wheels has been a wonderful advocate and provider of information on home safety, such as grab bars, etc. Removing barriers to seclusion and improving key home health and safety has been mentioned in this presentation. Will you be moving to add home safety services to your Medicare Advantage list of activities?
We could. I think that the whole issue of fall prevention is probably the door opener for that conversation, because that's certainly a huge issue for this population and for Medicare Advantage plans. So we certainly include that on the portfolio of services. It's part of our core to go in and do those safety checks and to make sure that any problems get addressed. And as part of that wraparound that we say, here's part of the value that you get when you work with Meals on Wheels versus other kinds of providers. And so it's part and parcel of who we are. If someone wanted to, if a plan was specifically interested in doing fall prevention or some other kind of safety intervention, we would certainly work with them. We are very flexible, and the breadth of what local Meals on Wheels programs are doing, that helps that along because they are engaged in so many different kinds of wraparound services.
Okay. Time for one last quick question here. Might a specific Medicare Advantage plan have concerns about paying for members served by other health plans?
Yeah, so you won't see a specific Medicare Advantage plan paying for members of any other health plan. They will pay for the services for their members. So they won't provide funding or payment for services to just anyone. They will provide payment for their referrals. So in our case, we follow a specific referral pathway, and only those that are referred through that pathway are paid for by the health plan.
Okay, very good. Well, presenters, it's time for us to wrap up here. Unfortunately, we've reached the end of our hour. But Lucy and Celia, I want to thank you for a great presentation. Thank you so much.
And thank you all for coming today.
Thank you.